Well,
they are close to 20 programs, so we just counted.
Tremendous. Tremendous.
Of course, 7 million people. It's a lot.
It is a lot. 20 programs is excellent.
But they're not smokers, so.
There's one thing.
Okay to start? Yep. All right. So by now you've heard about starting a program, and actually you've heard about evaluating a program. So this is the middle piece, which is maintaining the program or maintaining the benefits. So I'll just start with a very simple case. I just grabbed the last patient I saw in the last couple of weeks before I left, just to make 1 or 2 points. And then what I'd like to do is have a bit of a discussion. I have some slides to summarize, but I don't have to show them. If we cover it all in the discussion, I won't. So, and most of you are familiar with rehabilitation, or you're attached to a program, so I'm not talking to novices. I'm going to assume I'm not talking to novices. So this is a case, just an example. It's a woman who came into the program the first time in 2004, 68 years old, and as you can see from the description, at least 5 comorbidities. Well, 1 main diagnosis and 4 comorbidities, but as I think we talked about, and I'm sure your experience is the same as mine, it's unusual to admit someone who doesn't have 5, 6 or 7 comorbidities, and so she fits the bill. She completed the program. The usual things: treadmill, upper extremity, stationary cycle, interval training. But I have mentioned leisure walking, which we now include as part of the program, and which I found most rehabilitation programs will just send the patient away and say, do some walking, in your spare time, do some walking. There are a couple of things we found, which is that even simple walking, if you somehow supervise and encourage it, the patient's more likely to do it when they finish the program. And the whole goal here is to try to get them to do something after the program. Everyone, or nearly everyone, is going to do it during the program. That's not a problem. The problem is that if they're not adhering to the exercise training, within 6 months, at the most a year, but more often 6 months, they'll be back to their initial values. So the other thing about leisure walking, it's so easy to do. The patient goes to the therapist, tells the therapist it's time for my walk. The therapist clocks in the time. The patient goes off either alone, or sometimes 2 patients will go together. When they've had enough, they come back, report, get clocked in, and we simply capture the number of minutes of leisure walking. I'm mentioning this because all the other modalities are very familiar to you, but not every program does this. Now, what we found in a number of cases is that even when the 6-minute walk test doesn't change, the leisure walking might increase from 10 or 12 minutes to 45 minutes. This would not be a surprising example. Those numbers would be more usual. And there are several reasons. One of which is, I think the 6-minute walk test, which is a standardized test, excellent for research, it's been used a lot. But I'm not sure what we measure in the 6-minute walk test by telling the patient to go as far as they can in 6 minutes to do their absolute best effort. In other words, to do a maximal exercise test, practically, is the way we've trained them. And we've trained them to walk slowly, to pace themselves, to calculate their energy, to breathe using pursed lips. And then we go around and use a test which is completely the opposite of what we've been training. So, of course, we still use the 6-minute walk test, and I think probably we're going to change to the shuttle walk. But we're always going to use some sort of field measure of exercise, but we're also using leisure walking both as a training modality and as a way of evaluating outcomes. And there is surprisingly a correlation between the 6-minute walk and the leisure walk. It's not a very hard correlation. You can't predict one from the other. But by and large, I had mentioned some patients who don't improve in the one do improve in the other, but most patients who improve in one improve in the other as well. So I'm just mentioning it. I don't know if you guys do it. Nina, I don't know if this is something you do or...
It's very difficult to, no,
Standardize?
to control them,
Yes.
To control them.
It's
this is the problem when you do it just, walk
Right.
at home, around the park or whatever.
Right.
Do it in
We do it in the program.
In the program.
In the program.
Okay.
So it's one of...
I
But
thought it's leisure walking outside. Okay,
yes,
no.
the goal is outside.
Yeah, okay.
The management is inside.
Yeah, okay.
But you're raising something else, which is it is a non-standardized test. It is
Yeah.
not a reproducible
Yeah,
test.
yeah.
It's not interpretable. And therefore, I wouldn't advance it as sophisticated scientific measurement.
Yeah.
However, it seems to be quite useful to have a record of what the patients do. And I believe the patients tell the truth. They don't go in the other room and read the paper. Okay. Now, she went home in September, and this was a typical home exercise program. She was involved with cycling twice a week, upper extremity exercise twice a week. She had her own cycle at home, interval training once a week, and walking daily for 30 minutes. This is her pulmonary function, just to establish her credentials as having severe COPD, FEV1 just below 1 litre. She's hyperinflated, reduced diffusing capacity. These are typical patients that we see in pulmonary rehabilitation. So what I really want to talk about with you a little bit is the 6-minute walk tests over a prolonged follow-up period. Between August 2004, when she first came into the program, to February 2012, just before I made plans to come here. So what you can see in the light color is the rehabilitation sessions, and in the green, the follow-up measures. So between August 2004, September 2004, she did well in the program. She had quite a high level of exercise tolerance to begin with, starting around 400 meters. She reached 550 meters. That's really at the top end of the exercise tolerance that we see.
After 2 months.
After 2 months.
It's big difference.
Yeah, big difference. Now, I should say this is a 2-month inpatient program. I'm just going to get some water. It's a 2-month inpatient program. So if it would have been outpatient, it would have been 3 months. Okay. So what happened after that? What happened between September 2004 and October 2006?
Lasted in state for 2 years. This is what that's why I'm saying before that we said that it usually takes 6 months to deteriorate it down to the first point. And it's not true. The documentation and the literature says that once you finish 12 weeks of rehabilitation, it usually lasts for up to 2 years. And you just documented just that.
So what was she doing for 2 years?
Probably her daily living in a level of activity that allow her to maintain this level of 6-minute walk.
Maybe. In fact, she was doing her exercise program, which is why she lasted 2 years.
I'm not sure that that's what she done, but it doesn't matter how you call
Right,
it, whatever
well.
daily living is.
Well,
It could be that it was an exercise, but that was in her daily living, it's included exercise.
yeah. Well, those measures were made when we saw her in the clinic. We followed her up. We asked her the questions. The physiotherapist always checks them and has a log of the exercise program. So, whereas what you're saying may be correct, in this instance,
It was.
she was adherent with her exercise program, which is why she could protect and defend her 6-minute walk at 500 meters, which is excellent. So this is an example of a very compliant patient, which is why I chose her. So what happened in November 2007? Or-
Either she stopped or she got sick.
Exacerbation.
Okay, she had an exacerbation. Exactly right. And the exacerbation, as you know, is the enemy of rehabilitation. Everything you gain in terms of muscle function, quality of life, exercise tolerance, you lose quite quickly in an exacerbation. And for those who have multiple exacerbations, they rarely recover it, in my view, without another intervention. So, indeed, as you rightly said, November 2007, or shortly before, because this is a follow-up visit, she had an exacerbation. She was hospitalized briefly, treated with antibiotics, treated with steroids, oxygen, whatever she needed at the time. And
For how long?
4 or 5 days.
Ah, okay, only 4 5 days.
Admitted 4 or 5 days, and obviously there's going to be a few weeks afterwards before she's recovered. So we saw her in the clinic in November.
Excuse me?
Yeah.
What are the causes for the exacerbations if the patient is, following all the medical instructions, taking medication, doing the exercise?
Oh, what a great question. And if only I knew. The fact of the matter is people exacerbate. They get the flu, or they get an infection, maybe bacterial, maybe viral. Those are the commonest causes. Or something triggers their airway if they have a little bit of an asthmatic component as well. People will exacerbate. I wish I could say to you that if they did all their exercises, they won't exacerbate. That would be fabulous. It isn't true. I happen to believe that they will probably exacerbate less frequently, and the data is still a little bit unclear on this point as well. But they do exacerbate.
But you name some of the causes so they can try and prevent it. If they're allergic, if they're this or that. they can
Yep. Well, part of the
No.
That's right. Part of the comprehensive management is exactly that, to pay attention to vaccination, pay attention to correct use of bronchodilators, and even to teach the patient to identify an exacerbation in its early stage and seek either medical attention or start to self-manage. Well, that's part of the comprehensive management. But the sad fact is, they still exacerbate. Okay. So February 2008, she was re-enrolled in the program for a second time. Re-enrolled. Would you guys do that? Penina, do you re-enroll? Do you take them a second time? Do you take them for a second time?
Sure.
Okay. Anyone have a problem with taking her for a second time?
First, our HO allows and pay them in a calendar year for 3 months each year. So they're allowed to come for 12 to 25 times each calendar year without paying. And besides of that, so some of them, comes in January, stay till March, and then they're not paying and not staying, and then they come again in January.
Okay.
And there are many of them. And some of them come every time they have exacerbation, and that's...
So you will admit them again.
They pass their doctor's evaluation.
Right.
If it is possible, they return.
Right.
They start to do
Well, we do it a lot. We will readmit people. We don't readmit them by the calendar, so it's not that we take them 1 year later and then 2 years later, 3 years later. If they're doing fine, we leave them alone. We follow them in the clinic. But if they have some sort of event, and based on symptoms or based on their medical history, we will quite happily re-enroll them, particularly someone like this, because first of all, she did well, and second of all, she continued with her program. So it's an ideal patient. Someone you would want to try again. In terms of compliance. So compliance was very good. So between February 08 and March 08, she was in the program again. Any thoughts? This is her rehabilitation. Any thoughts on that change?
Training effect. I mean,
Why is it lower?
gain the training effect that she achieved before, or whatever.
Yes, but
Why
not
did it
quite.
go from the start?
No, I
They will
mean,
never reach...
I'm interested in your thoughts on that.
not really before, but above the initial point.
Right. Well, if you can see her results in March 2008 were still below her follow-up data from 2006 and certainly below the results of September 2004.
Still a training benefit
Yep.
compared to February.
Yep.
Yeah.
It helped her.
The tissue more than what it was in the beginning.
Better, that's why it's been called chronic disease.
It's a chronic
It's a
disease.
progressive chronic disease.
Yes.
So she improved as much as she could, and and it's never gonna come to what it was 2 or 3 years ago, and it's fine.
Okay.
Now she needs to maintain that.
She needs to maintain that. What do you think? Go ahead.
She didn't.
She didn't.
Didn't she?
July 9.
In July it's gone down.
So what happened in July 2009?
Either another exacerbation or she didn't exercise.
Okay. She fell and broke her wrist. She became immobile. She didn't go out much. She became demoralized, a little bit depressed, and had a little bit of a sense of hopelessness for the first time. So, not yet. We're not there yet. We're on October 2009. So we readmitted her, her third occasion. And just as you pointed out, once more, there was an improvement. But at that point, the improvement was not as good as the previous or the previous. And then, if you look at the overall scope, from here through the programs to here, broadly speaking, what you can see is, even with the improvements, there's a gradual deterioration. And look at the time frame. We've gone from August 2004 to October 2009. 5 years. So in March 2010, we introduced a rollator to her. May I ask you, how many of you are using rollators?
You mean the patient?
Yeah. How many are using it in your program, not using it for yourself?
So, what is rollator?
The rollator guy is here, Ilan.
הליכון.
Okay. And since he was kind enough to come, he's just going to take 2 minutes to show you this rollator.
אתה מוכר את זה עכשיו, אני אומר.
אנחנו מוכרים את זה, כן, מייבאים ומוכרים. למה אנחנו... והם מקרה הכינות. אני מפולקו. פולקו זו חברה שעוסקת באביזרי שיקום. התחלנו מהנושא של רולטורים, מה שהרבה קוראים להם הליכונים. אנחנו מתעסקים בהליכונים, ברולטורים עם 4 גלגלים. זה הרולטור המתקדם שביניהם. המוצר עצמו מאפשר עוד פעם תנועה חופשית לכל מי שמשתמש, הוא יכול ללכת בבטחה ולהפעיל את כל העומס שקיים בזמן ההליכה ויכול להפעיל את זה על הידיות ולהמשיך ללכת בצורה בטוחה. המוצר הזה גם ברגע שהוא מתעייף הוא יכול לנוח, לעצור ולהתיישב. זאת אומרת, נועל זה עם מעצורים, נועל ומתיישב עליו. יכול לשאת 125 קילו, זאת אומרת, גם לאנשים גדולים. אם תשימו לב, הרולטורים האלה שקיימים בכמה וכמה דגמים מופיעים עם מושבים שונים. כאשר המושב גבוה יותר, קל יותר לקום, מטופלים מהסוג הזה. זה במקרה הרולס רויס של הרולטורים מבחינתנו, הוא קל יחסית, 7.5 קילו, הוא מתקפל בצורה מאוד נוחה והוא לא כבד. נושא של מעברים, מדרכות וספות מדרכה, אז לא צריך להרים את הרולטור כדי לעלות על השפה, יש פה מין טילטר כזה שמסייע לו לקום. זהו. אפשר להעמיד פה את כל האביזרים הנלווים אם צריך, מחזיק בלון חמצן ומקל הליכה אם צריך, קביים, כל דבר.
והמחיר?
המחירים נעים, זה הרולס רויס, זה 3,200, אבל יש גם ב-750 ומקליט אותי. ב-1,200, ב-1,500, ההתאמה היא לכל בן אדם. מה שחשוב מאוד זה הנושא של, יש הליכונים שניתן להצמיד להם מעצורי גירה, זה מעצורים שיושבים על הגלגלים האחוריים, לאנשים נטייה ליפול אחורה או שזה רץ להם מהר מדי, אז אני שולט לו על התנועה של הגלגל האחורי.
זה מחיר מוזל של 250. לא, סתם.
לא, תאמין לי שלא.
Okay. Okay. Thanks. That's great. So we finished with the rollatorim. And that we can take that one too. So when do we use it?
Like I just like how much cost babies,
Right, a stroller for a baby, yeah.
Yeah, same price.
Same price. Wow, that's really interesting. I understand.
Fiat Uno.
The basic, yes, the basic. Well, that's a very interesting way of looking at it, because we have one advantage here is that the patients don't pay for it. We prescribe it.
We do have systems over here that they don't have to pay.
That's great.
Privately, we do have the Atzara as only
Right.
in other places.
But
It's
presumably,
not as fancy as
but I suspect that,
as fancy as this one. Hey.
okay, I suspect that many of the patients don't have that sort of coverage and would have to pay if they didn't have it. At least that's what the last two groups told me. When do we use it? That's a good question. Different circumstances. The first is if we see somebody who we know is an adherent patient, done well, 3 times in the program, and you can see there's an overall deterioration several years later, then you can predict function is going to go down. So we try to use it to improve function. In her case, she's managing, well, we tested her with the rollator. She was doing 400 meters, so probably without the rollator it would be less, maybe 350 meters. And we use that as a sort of cutoff, not as a hard scientific rule, but in clinical practice, if they're doing less than 350 meters on a 6-minute walk test, we like to test them with and without a rollator. Baseline, unaided, without anything, just walking. If they're less than 350, we like to test them with a rollator. Now, some of them find that they are less short of breath and they can walk further. Against that, there is a certain stigma because you're using a device. And actually, that's why he took the other one away. I didn't even show it. It looks like a wheelchair. It's exactly like a wheelchair. And we wouldn't really consider that type of model because it really promotes a sense of illness and not wellness. So that's when we start to introduce it. Patients often will train in the program with it. They'll use one of ours. They're not that keen to go home with it because of the stigma. But quite often we'll get it for them and just leave it in the house. They can leave it in the house. And a time comes, let's say they're having an exacerbation or they're having some trouble balance, and they find it very useful, and then they start to use it. So I wanted to sort of introduce that, although obviously they're around in Israel, but I don't think they're being used in the rehabilitation programs perhaps as much as we are.
What about the work rate? It goes down when they use the rollator. So maybe the advancement is also, when you use it, so it's easier to walk.
Yes.
You can walk more. So
You can walk longer.
But the work rate is lower.
Yes.
So you progress.
Well, that got raised before. I'm not sure that you become physiologically harmed. I think what you're saying is you detrain because
you don't detrain. Just harder to make an advancement with the rollator.
yeah,
It's
but
a trade-off.
it's a trade-off. It is a trade-off. What we're trading is to increase autonomy and increase activities. That's what we're looking for. The other point we're looking at is, and it's becoming clear to us more and more, is that these patients tend to have more falls. They are at a higher fall risk than healthy elderly. And if you take a fall history, to be honest, we never used to do it, and it was only when we began to become curious about it. Now we routinely take a fall history, and we routinely do tests of balance, 2 or 3 simple tests of balance. We now have data suggesting that their balance measures are less than healthy individuals. When you do, sorry, do you want to say? Oh yeah, yeah. You can do the trying to think the ABC. There's one called the ABC balance test. Actually, the physiotherapists know this much better than I do. But,
Berg.
There's the Berg balance. That's right. There's a Berg balance scale that has normal values. There's something called the ABC, and there's 2 or 3. We use the Berg. So it's something worth thinking about, and if we have people whose balance is impaired, we will encourage the use of a rollator. So there you are, she had a rollator. Eventually she required supplemental oxygen. Again, no, we're several years on, 8 years later. Disease progression was handy too. They could put the oxygen in the rollator, and that was the last time I saw her in February of 2012. So let's go back to this concept of maintenance. Let's talk about how many ways we can think about maintaining the gains from the rehab program. So I've done all the talking. Why don't you give me a few suggestions?
What you're looking for?
What I'm looking for is, I know the patient has done well in the intensive rehabilitation program. They've improved their walk test, their quality of life. I want to maintain that. I'm concerned that many patients who don't continue with the exercise will deteriorate, and quite quickly. So I need a rehabilitation approach that goes beyond just the initial program. So I'm asking you what suggestions you might have, what you would do with your patients, how you would approach this problem. Okay, we've covered one. One is re-enrolling them, following them and re-enrolling them when there's a deterioration. So that's one way of maintenance. Can we talk about some others?
I have suggestions from my other head. I'm working in cardiac rehab.
Okay.
So we have a group of maintenance phase 4 people after MI, 10 years, 15 years. So they're coming like for the gym, but they have physician supervision and exercise physiologist and exercise specialist. And this is not group exercise, this is like a gym. They're coming in the hour that they comfort, but they know that they're a physician in the facility and they have their file. You know that today doing 40 minutes walking on 5.5 kilometers with 4 level degree, and then cycling 20 minutes, and then strength training. And I think if they stay in 15 years after MI, I think this can be also in pulmonary rehab.
So you've raised, when I'm listening to you, I'm hearing 2 things. One, the concept of a maintenance program. So you don't leave the patient when you finish the rehab program. You have to have, or it's desirable to have, some sort of maintenance program. We do. When they finish the intensive rehabilitation, they come back to us. The ones we enroll, they'll come once or twice a week, or even just once a week, or even once in 2 weeks. But we stay in contact with them. They can come in. They don't need to be registered or anything. They can just go to the area and do their exercise. There will be a therapist there. So it's the concept of a maintenance program, which is one way to maintain benefit. But the other thing you touched on, which I think is very interesting, if I understood you correctly, is to try to move the maintenance out of the healthcare environment into the community environment. And we've become very interested in this as well. So what we now do is we train the fitness instructors in the local community gym, and we train them in COPD management. They're very excited to do it because it's a new experience for them. And then we send the patient out of the healthcare system into the community system. We like that for a couple of reasons. First of all, then healthcare is, if there is a cost, healthcare isn't paying for any of this, so it's off the healthcare resources. But second, it removes the stigma of being in a hospital because you're unwell, and puts you into a community where you're seeing healthy people exercising all around you. I don't know what you guys think of that, but...
So even the severe one?
Everyone. Everyone who wants it and can do it. Yeah. Well, we're still in the pilot phase now. We've been doing it only for a year, and the preliminary results look very encouraging indeed. We're finding that over that year they don't just maintain, but they actually gain further.
So they'll go train the community with supplemental oxygen, etc.
Whatever they would have, everything that they would take home, they take to the local community centre. Oxygen, rollator, or neither. For many patients it's neither. And they're training supervised by a local fitness instructor.
Is it a gym? Like a normal gym, yeah, a normal gym.
A normal community gym.
Well, what's in community?
Community
like
means...
home place or something like...
Well, home place is fancy.
Yeah,
home place
sure.
is fancy.
Okay.
So,
Yeah.
and I don't know whether they have this in Israel, but in Ontario, the community provides exercise facilities for the public.
So it's different.
And they're very inexpensive.
We do have only the resistance, facility like some in the beach. You can see that.
Yeah, I've
but
seen that.
The communities that don't support,
Yeah, well, the great advantage we have is our winter,
Yeah,
because
okay.
Canadians play hockey,
Yeah, okay.
and there's a huge demand to have community hockey centres, and of course these centres became much more than just hockey, so gymnasium and stuff like this. So, well, we are using it, I guess we have that opportunity, and Home's place is too expensive. It would be great if you could afford it, but most of these people are not in that income bracket. Anyhow, as I said, it's pilot. It'll become a randomized controlled trial. Let me tell you about a couple of other trials, because then I won't show slides. We can just sort of chat a bit. One trial that was both bad news and good news. Here's the trial. They took 150 people who completed rehabilitation, and they randomized them to a supervised maintenance program where they were attending once a week, and there was telephone contact, and there was someone who they could talk to. The program went for 1 year. And then they measured them 6 months, 1 year, and 2 years. So half received usual care, which is the term they use when they mean no care, and half received this maintenance intervention. What they found is the maintenance program made no difference at all. It just didn't matter. About half the people in the maintenance program would walk regularly, and about half the control people would walk regularly. So that's the bad news. The good news is then they could collapse the data and just compare regular walkers with non-regular walkers. What they showed, which is why I like the paper, is that regular walkers 2 years later have a better quality of life and a better exercise tolerance than non-regular walkers. So walking is good, which takes us back to some of the remarks that Kylie was making about the Australian program, where they really emphasize walking over cycling or treadmill training. It's one of the few papers that showed that walking improves quality of life and exercise tolerance. So I don't know how you make them walk, but if you can get them to walk, it seems that it is a good thing. Yeah.
One of the things that I sell often in each of my courses and everything is climbing stairs. I believe that this is the goal of everything, because the benefits you can get from climbing 4 stairs in the time it takes is probably like 40 minutes of walk or leisure walk outside. So one of the things that I recommend all my patients is to stop using elevators and walk up and down the stairs. And if they have 5-10 minutes spare time between news or just waiting for the grandkids or just whatever, just go up and down one flight as many times as they can. And some of my patients reach 25, 30 floors in 10 minutes, which is amazing.
That's a lot of walking. It's a lot of stairs.
Right, and they do that in my place, and I count, so they can't cheat. So that's how
stair climbing is it's maximum oxygen uptake, right? It's a VO2 max.
But the time it takes to do that, it's not 45 minutes of walking.
Right.
I can tell you that me, myself, when I don't have time, what I do, I do 15 minutes, I go up and down 60 flights or whatever, and that's intensive training, and I'm not wasting an hour of running or walking or whatever. So this is one of the things I do recommend to each of my patients, and usually in each exacerbation, I tell them, just start with 5 steps and then stairs, and then do 10, and then do a whole floor, and just do many more and more each time. Once you can do 10, you definitely can start doing, 30 minutes of activity anywhere else.
And do you think you are strength training or endurance training?
I probably do endurance training, definitely. And it doesn't go without strength. Even pedaling and walking is strengthening. You need to walk against your gravity, so you're strengthening. That's how they got stronger, But you can't do one without the other.
Well, it's interesting. I'm afraid to say most of my patients probably couldn't climb more than 1 or maybe 2 flights of stairs, so yours are obviously motivated to
I'm telling you,
do more.
there are some programs which I start with climbing stairs. I'm standing in the hall. I mean, people in the hospital just know me and go by and laugh at me, and they see 60 patients go up and down, up and down, up and down, and I'm counting.
Okay. Anyone else have that experience?
Right?
Yisosra, you had such a experience? No. Well, that's why we're here, to put our heads together. Any other thoughts about maintenance? Huh?
Yeah, it's the problem.
It's a problem. So
one way to escape it is to keep them throughout life in the rehabilitation program, and then you're set.
yeah. Well, yeah, but they're not going to want to come to an institution forever, and that's why we're looking at alternate environments. So let me just mention a couple more. One is to start. Sorry.
Home, you can do follow-up with home care.
You can do follow-up with home care, and here I think you have an opportunity in Israel because you have these free, at least in general rehabilitation, you can have up to a certain number of visits at home, if I understand correct. Is it 12? But do you use that for pulmonary rehabilitation?
You do, but you need to be pretty sick and unable to leave the home in order to get it.
Yeah? It's not that easy. Because I think it's an interesting opportunity for maintenance, and I think it's also an interesting, a great little clinical research study to try and identify whether that supervised care at home compared to no supervised care at home is going to impact on outcomes. If it's only 12 sessions, it's probably not enough.
Who will do it?
Well, who does it now?
Yeah, you can do it, you can do it up to 25 times if it's if the person didn't go to
A rehab.
rehab, and a lot of them, especially up north, don't go to rehab because it's very far from the home.
Well, I think you've got to, if that's the case, if you can do it 25 times, then you could do 8 weeks of 3 times a week, which many people would call a rehabilitation program entirely at home. I think it's worth looking at. I think it's a very interesting thought. Maybe it's an opportunity. Well, one other approach is to start them earlier, of course. We've sort of talked about that a little bit, which is the initial trials of pulmonary rehabilitation excluded anyone who'd had a recent exacerbation. You had to be at least 8 weeks away from an exacerbation to be enrolled in the trial. That was a requirement. But now what's becoming clear is that you can begin the rehabilitation either when they are in hospital, actually in hospital, or immediately after they leave the hospital, and that you don't have to wait for what we used to call clinical stability. It's not necessary. So another way of maintaining benefit, because I'm sorry, that's me. Actually, it's me to say we've done 40 minutes. The earlier you start, and if you consider that rehabilitation, the exacerbation is the enemy of rehabilitation, then the earlier you can start to treat them post-exacerbation, the more chance you have that they'll get back on their feet. Lastly, just want to mention a study from, I think it's either Hong Kong or China. It's Asia. The first author's name is Liu. And they've had success with something that I've had no experience with at all. They've randomized patients into receiving a cell phone mediated music program for 40 minutes at a time that the patient has chosen every day. So it's cell phone induced exercise. They put on the speakerphone and off they go. And they have found over a period of months that the cell phone group are functioning substantially better than the non-cell phone group. It's again a wonderful Israeli opportunity because I never met anybody here who didn't have 1 or 2 cell phones with them. So, well, sorry about that. But you see, I have 2 phones. I have an Israel phone too. So again, I think it's very interesting. You know, we're always trying to look for new things. So one approach to maintenance might be to somehow use some electronic approach through a cell phone or something like that. Any other questions? Comments? Okay, so we're done.
Thank you.
Thanks, guys. Thanks very much.